The idea is to present this case. The patient came to us with 65 lady with a massive proteinuria. Actually, patient got admitted into our hospitals in the month of July. 5 months back, she came to also our hospital, admitted in the cardiology ward with history of the breathlessness and there's mild edema was there and anemia. So patient was discharged with a diagnosis of hypothyroidism and hypertension and anemia. Subsequently, after 5 months, when patient came to with presentation of the 2 months of the swelling of whole body generalized anosarca, and subsequently found there is a hypoalbumin persistent albumin hypoalbuminemia. At least we have given 20 infusions of the albumin to minimize the fluid overload, so that we can do the biopsy. And biopsy subsequently found to be case of the amyloidosis. So what is amyloidosis? That is important. This presentation we can. In my setup, I have got I think 2 patients earlier, but this is 3rd patient. 1 patient admitted the same thing in the cardiology ward there 10 years back. Patient was admitted with the cardiac and the renal involvement. We did also biopsy. Here this is what is amyloid. Here Rupert Biko is the pathologist who has coined this name the amyloid because it on the light microscope when you see the tissue it looks like the cellulose or starch. Amyloid is refers to the diseases caused by extracellular deposition of insoluble protein fibrils in the tissues and organs. So amyloidosis compares a diverse group of systemic and local diseases characterized by organ involvement by extracellular deposition of fibrils composed of subunits of variety of normal serum proteins. This is the homogeneous you can see the homogeneous pink extra. These are the places these are the amyloid deposition is there. In the light microscope you can see. It is this non-branching protein that is 7.5 to 10 nanometers in diameter and beta-plated sheet, this one. So you can see this is the beta-plated sheet which can be seen in the Congo red staining. You will get the green bisphenol. This is the place what we get it in the current, which is diagnostic for the tissue biopsy you can be. And there is mainly varieties we got the primary and secondary, and that is in the primary is the amyloid light chain, there is immunoglobulin light chain, and the associated is the that is secondary cause the amyloid receptor. Third variety is the familial group, AF that is. So precursor of amyloid receptor that is AA means that is serum. Sorry. Amyloid associated protein from liver that is this is the chronic inflammation or chronic infection. In case of tuberculosis you can get in the and other diseases will get it, and amyloid light chain immunity which is a primary cause we usually get in the multiple myeloma or non-Hodgkin lymphoma or lymphoproliferative disorders. So what I have told you that is systemic amyloidosis is primary or secondary. It may be also localized, it may be senile cerebral, this may be senile cardiac and type 2 diabetes. These are the localized amyloidosis. You can see in the primary case amyloidosis, there may be multiple myeloma, another is the non-Hodgkin lymphoma. Here the type of this chain you can see the amyloid AL means light chain. I mean AL AL is the amyloid light chain, and we get the light chain there is 2 things kappa or lambda, there is the ratio should be 70% more than that. And in case of the chronic secondary, you get the chronic inflammatory, that is AA, that is serum amyloid associated that you get in chronic inflammatory diseases, or chronic infective disease, that is inflammatory disease, inflammatory bowel disease you can get also, or infective in the tuberculosis. And hemodialysis associated where you get the beta 2 microglobulin, AB2M, that is that is that the AV2 microglobulin that you get the usually in end-stage renal disease you get, and that is into maintenance hemodialysis. Rheumatoid arthritis is the secondary cause where the chronic lymphangitis. So chronic lymphangitis there is two, one is the rheumatoid arthritis or the other chronic infant bowel disease. And localized amyloidosis, you can see the senile cerebral amyloidosis, Alzheimer's disease. We got the A beta, that amyloid, and type 2 diabetes also we can get. And these are the diseases amyloid which you get the diseases, different diseases which get the one is the multiple myeloma, which is common. This patient is we are taking as a case of diagnosis subsequently because due to present the M band we got this protein electrophoresis. That is AL varieties. Then the second was the rheumatoid arthritis tuberculosis AAA. Senile systemic that the TTR, the thyroidine, transthyretin that you get it. Familial is the there is that another variety, and Himalaya is associated Alzheimer's disease and medullary carcinoma thyroid. We get also calcitonin here. So what is AL amyloidosis? This derived from the immunoglobulin light chain can occur alone in association multiple myeloma, malignant lymphoma, mostly non-Hodgkin's lymphoma, and macroglobulin, unstrong macroglobulin. Amyloid mycosis is the light chain deposition disease has a similar pathology to AL amyloidosis, and primary difference is that deposited light chain fragments do not form fibrils and do not endanger deposition of amyloid protein. And it is wide spectrum organ involvement. It can occur in the heart, lungs, GI tract, eyes, the tongue, mouth, whatever you get. And is most common is the 70 to 80% we get amyloid AL varieties in the first is the kidney, then second is the 50-60% we get the cardiac involvement. So kidney involvement, that is will be massive proteinuria. Usually when we get more than 8 to 10 grams liters, what we have got here. And there is edema and hypervolemia and mild renal dysfunction and rapidly progressive renal failure. This fellow has got the 2 months of the history. We get the patient with the renal failure. And we did some dialysis also become one. These are other patients, that is waxia appearance of intracellular. This is raccoon or eyes sign, that is this is due to the arterial the deposition of the amyloids or the factor 10 deficiency. That is raccoon retinal sign. This is the in the eyes. Periorbital, you can see that is hemorrhagic ecchymosis will be there. Cutaneous hair conqueror. And there is macroglosia. And gross lymphadenopathy will get 10%. Then another is the secondary disease, AA varieties amyloidosis, which is common, as I told you, in the chronic inflammatory or infective varieties. And these are patients we can return. It results from the proteolyte cleavage, SAI protein, and SAS is an acute phase reactant produced by liver, and sustained high concentration of CSF prerequisite for AA varieties amyloidosis. So what are the diseases? What I have seen, one is chronic inflammatory disease, rheumatoid arthritis, inflammatory bowel disease, bronchiectasis, tuberculosis, FMF. And in AA varieties, kidney is the most frequently affected target organ. Primary clinical manifestation is proteinuria. The underlying disease usually is long-standing. And there is active inflammatory typically is present when amyloidosis becomes evident. Hereditary, which is transthyretin, that is TRR, and there is also apolipoprotein. These are the protein fragments. This prevalent. What happens to amyloidosis? There is a misfolding of the protein fields. The normal is misfolding, so we get the amyloidosis. So there is the hereditary amyloidosis caused by good one, sir. Caused by deposition of genetic variant protein associated with mutations in the genes for transthyretin. The causes are transthyretin, apolipoprotein A1 and A2, and lysozyme and fibrinogen. These are the all the protein variants. So typically they are associated with the polyneuropathy and cardiac involvement, but can affect also kidneys. Renal deposits may be clinically silent. Isolated glomerular involvement with no amyloid in the tubules. interstitium or vessels has been found to be a character of fibrinogen. And renal failure develops rapidly. So renal amyloidosis is clinical event. Renal impairment occurs mainly in AA and AL amyloidosis. Our case was the AL variety, that is amyloid light chain, the demonoid light chain. The deposition of A beta to microglobulin occurs in patients on prolonged dialysis, those in case of end-stage renal disease. But diagnosis of the kidney biopsy is unexpected. 8 because of fibrils are particularly important for kidney. So this is the NEGM that 2003. The incidence of amyloid in patients with nepotism or proteinuria was found in 2% to 12% of native renal biopsies. Amyloidosis without therapy usually progress to end-stage kidney disease, and the deposits may also regress. So diagnose what are the criteria. You can, it is very difficult from the history. You have to first go for this. Then you have to do the things. No blood test can diagnose or exclude amyloidosis. Usually relies on clinical suspicion. From the history, we have to go and define it. And the possibility supported by underlying chronic inflammation, that is A varieties, that is due to chronic inflammation. In case of rheumatoid arthritis, inflammatory diseases, underlying plasma cell dyscrasia, family history for the familial amyloidosis, and evidence of renal dysfunction. Special strain, that is what we past secretary in biopsy. Congruent is the important. More than what we do in the case of congruent staining is the diagnosis of the amyloidosis. In case we sent to also, we sent to biopsy to the Bangalore Manipal Hospital. They give this biopsy reports with the study. So this is a special strain and amyloid Lugal-Sardin Brown syndrome specimen. This congruent, what in the polarized microscope you will see. These are the bisperous green color, this apple green bifringes. These you get, that is the most diagnosis for the amyloidosis. Normally it remains a big red, but in case of congruent, you will get in case of amyloidosis, this is the green color. Amyloid deposits in the mesangium. This is a mainly this is mesangial matrix. In the glomerulus, the mesangial there will be deposition amyloid protein will be okay. We'll get these things together. So these are the amyloid deposits. This is the mesangium. This is the glomerulus. Full is the glomerulus, and the glomerulus cells you can see only mesangial matrix. There is a deposition of the amyloids. What we are getting here. So clinical manifestation, if it involves the kidney, there will be nephrotic syndrome, proteinuria, renal failure in the instance. When there is strong, there is macroglossia, what I have shown you already, and malabsorption, heart and cardiomegaly, that is resting cardiomyopathy, and subsequent heart failure. Bone marrow involvement in case of multiple myeloma, that is fractures, multiple myeloma. We have got another patient which is admitted in our hospital now in the female medical ward. Patient admitted 1 month back with multiple fractures. Fracture neck upon another place, 2 places. She is around 65, 70 years lady. So just planned for the operation, so surgical correction. Subsequent patient was anemic condition, so date was fixed up, and we sent the patient back to their respective place. Subsequently, she came to us with the features of the restlessness, and patient we found to be urine. So we diagnosed the case as the multiple myeloma. Patient diagnosed this case of multiple myeloma. We evidenced by the serum protein electrophoresis immunofunction test. And now patient is under hemodialysis, patient is bad. So patient has got also pacemaker. We are very difficult to get the access. So we are going with only femoral catheter. We have planned for the CAPD because there is no other route to have. Patient is not conditioned to come from a different place. She belongs to Kharagpur. Difficult to come for hemodialysis with the fracture case. So we have planned for the, when the condition improves, we will go for the CAPD. So it may be kidney, bone marrow involvement is there. So laboratory findings for the multiple myeloma, there will be presence of amendment in electrophoresis, what we have got. Benzoate protein in the urine or increased light chain or monocular Ig. You can see for the The kappa lambda, you can see the embedded kaka. Here you can see that this is the normal serum, and here you see the band here. The presence of the band in electrophoresis. Similarly, you can see we have the weekly pass positive. These are the things, these are the amyloid deposition. Similarly also, the opposite right side also, we have also deposits are there. And amyloid do not stain by silver staining. Occasionally may stain with silver stains and show pictures like stone silver. This is the congruent to the polarized light. We can see here the difference in this way. This is congruent. We can see where in the normally it should be see the green red color vector, but in case of polarized microscopy, we can see this congruent like green apple green beach appearance. So that is the diagnosis. Caution is advised regarding over-interpreting collagen as amyloid. That is both are different because deposits of amyloid are frequently very focal and irregularly distributed in tissue section. Multiple and thicker section may need to be examined. So detection of amyloid from other states or techniques, fluorescence, thiazide and methyl violet, supported cyanide, and they are less specific. These are not specific. And character will randomly disclosed, rigid, non-bunching, variable long-term behavior. And electron microscopy, that is also you can see the things. And drugs pathology renal amyloid, you can see that there is the enlarged kidney and it lacks pale waxy appearing in surface. Weight of kidney did not correlate with the renal function. The site of renal amyloid deposition inversely proportional to the amount of amyloid. This same thing microscope you can see now also. So microscopic renal amyloidosis, it may amyloid deposition may be segmental, it may be diffuse messenger, it may be glomerular or pure basement membrane pattern. So these are as per histology like SLE, we have got this classification pathology histopathology classification 0 to 6. No 0 is class 0 is no amyloid deposition, minimal amyloid deposition class 2, class 1, and class 2 is messenger minimal amyloid deposition, class 3 is focal messenger capillary amyloid deposition. 4 is the diffuse messenger capillary amyloid deposition, 5 is the membranous, 6 is the advanced form. This is the early segmental, what we are seeing now. It is easy to measure. These are the diffuse form, mesenchyme is uniformly expanded by the deposits. And this is the nodular form, mesenchyme is assembly expanded by amyloid and distant form diabetic nephropathy or the form. And these are subepithelial, they do nothing. So green color you can see it, and this is the subepithelial. Here is correct. This is electron microscopic deposits you can see from the fibrils will be there. This is the epithelial surface is the you can see deposits are there. You can here see the deposits. This is electron microscopy study. So rarely patient has to be seen. Interstitial amyloid are seen in 50% cases, generally begins in area, etc. It usually inverts to the mesenteric, it also inverts to the tubules. Once tubules invert, that is the renal failure progresses. So, A amyloid is certain amounts of transparency, may show amyloid deposition limited to the interstitial or medulla. Such vessels present in the renal were not associated with proteinuria. So, microscopic renal vessels are often involved. Arteriolar deposits being most frequent, followed by diffusion petechial. Thank you. And the treatment already we have discussed, that is the recently we are giving thalidomide, dexamethasone and bortezomib. Or in place of thalidomide, we can lenalidomide and dexamethasone and bortezomib. Also high dose mefla along with the steroid, followed by bone marrow stem cell transplantation. So these are the line of therapy. Any question?